I'd like to thank the ISN for the opportunity to interact and to be able to provide educational opportunities like this at an international level. And thank you to all of you for attending today. This webinar is being recorded and will be available later at the ISN website. We will have a question and answer period after this session, and you can actually type your questions into the chat box, which is available, and we'll have a moderated discussion after the presentation. So the topic today is acute hyperkalemia, conclusions from a KDIGO Controversies Conference. So as you're all well aware, I'm sure, hyperkalemia is a common electrolyte disorder, probably one of the most common, associated with underlying conditions predisposing to its development, such as kidney disease and heart failure. Certain medications commonly used also increase the risk of hyperkalemia. And in 2018, KDIGO convened a conference to identify evidence and address controversies on potassium management in kidney disease. And I had the pleasure of working with Dr. Gregor Lindner at that conference. And this presentation today actually summarizes the clinical evidence for the evaluation and management of acute hyperkalemia. And so our learning objectives today are to review the definition of acute hyperkalemia, symptoms and consequences, the diagnosis, as well as management. And I have the pleasure of introducing you now to our speaker today, and that's Dr. Gregor Lindner. Dr. Lindner studied medicine at the University of Vienna, where he was already a member of a study group on electrolyte and acid-base disturbances during his time as a medical student. After completion of his residency in internal medicine, he specialized in emergency medicine and is currently the head of the Department of Internal and Emergency Medicine at the Catala Hospital in Switzerland, where he also leads a research group focused on electrolyte disorders and acute kidney injury. And as I mentioned before, I had the pleasure of working with Gregor while we were undertaking this KDIGO Controversies Conference. And he's probably one of the most responsive and dedicated individuals I've had the opportunity to work with. So Gregor, thank you very much for taking us through this webinar and presentation.
Thank you so much for the nice introduction, Brenda. Ladies and gentlemen, welcome to our webinar on the acute hyperkalemia session. It is my pleasure to present today the conclusions from the KDIGO Controversies Conference. We heard it before. I would like to present today some new aspects and evidence concerning the treatment and management of hyperkalemia. We will also try to focus on the issues important for clinicians in daily clinical practice. I would thank Brenda for the nice introduction, and also I would like to say thank you to the KDIGO and the ISN for the opportunity to serve as a speaker today. First, I would like to show the disclosures made for the current webinar. Moving on to the definition. What is acute hyperkalemia? Acute hyperkalemia can be defined as a potassium level above the upper reference limit of normal of the respective laboratory, which is not known to be chronic. The fact that it is not chronic is especially important since acute and chronic hyperkalemia can and should be distinguished, since there may be differences in terms of symptoms as well as management. Concerning the determination of K, it should be said that the determination is possible from serum as well as from plasma. Well, it should be said that serum potassium is approximately 0.1 to 0.7 millimoles per liter higher in serum than in plasma. Point of care measurements can be helpful due to the rapid availability of the results. However, you should use the results with caution. Coming to a classification. As with other electrolyte disorders, a classification of the severity of hyperkalemia is challenging, since the time of onset, the grade of the derangement, as well as associated symptoms may play a role. Still, during the KDIGO Controversies Conference, we tried to the best of our knowledge to find such a classification. What can be seen on the present slide is a classification for hyperkalemia, which combines the level of potassium and the presence of symptoms as expressed by ECG changes However, it should be noted that we do know that in some cases, even very high levels of potassium can present without ECG changes. This makes it a little bit tricky. Still, it can be said that the high inter-individual variability can and must be assumed. Coming now to the prevalence. In general, we can say that hyperkalemia is a common phenomenon in daily clinical practice. Depending on the cutoff used to define hyperkalemia, its prevalence was described to be between 4 and 9% in the general emergency department. These numbers make clear that hyperkalemia is relevant and its etiology and management should be kept in mind by us physicians. Also, it should and makes clear that providing standards of care and regular teaching on this issue probably will be of benefit for the affected patients. Hyperkalemia is also a feared complication of chronic kidney disease as well as acute kidney injury. Interestingly, there is only little data concerning the prevalence of hyperkalemia in patients with acute kidney injury. Only recently, the first explicitly investigating study investigating the prevalence of hyperkalemia in acute kidney injury was published. In total, in a collective of about 20,000 patients presenting to an interdisciplinary emergency department, it was found that as many as 13% of patients with acute kidney injury at presentation to the emergency department had hyperkalemia. The proportion of patients with hyperkalemia was by far higher in those who had pre-existing chronic kidney disease and new onset of acute kidney injury than in those with previously normal kidney function and now acute kidney injury. Also, as a side note, but of interest to me, the high prevalence of hypokalemia in these patients, it was 11% in patients with acute kidney injury. Moving on to the etiology and risk factors. Knowing about and being aware of the potential mechanisms leading to hyperkalemia is of high importance for the successful management of patients with hyperkalemia. In general, as with disorders of serum sodium, hyperkalemia can only develop by either an increased intake of potassium, a decreased excretion of potassium, or a shift from the intra to the extracellular compartment. Major and well-known risk factors for the development of hyperkalemia are a worsening or pre-existing reduced kidney function, the presence of certain comorbidities such as heart failure, diabetes mellitus, or several medications, for example, antihypertensives, especially inhibitors of the renin-angiotensin-aldosterone system, or potassium-sparing diuretics, are major risk factors for the development of hyperkalemia. On this slide, you can see an overview of common and important risk factors for hyperkalemia. As mentioned before, kidney disease is a major factor, as well as heart failure. Moreover, pseudo-hyperkalemia should also be kept in mind as a possible cause for elevated potassium levels. Pseudo-hyperkalemia is often caused by fist clenching, long tourniquet time, prolonged processing times of the blood samples, or mechanical tremor. If pseudo-hyperkalemia is thought of, a second determination of potassium should be performed, preferably in a way which makes results rapidly available, such as with point-of-care testing, although results might be not so exact as with laboratory measurements. Certain drugs are also major contributors to the development of hyperkalemia. As mentioned before, inhibitors of the renin-angiotensin-aldosterone system, potassium-sparing diuretics, non-steroidal anti-inflammatory drugs, but also beta blockers or heparin are important risk factors for the development of hyperkalemia. In the table, you can see very commonly used medications such as heparin, penicillin G, but also immunosuppressants or muscle relaxants are important risk factors. Concerning the symptoms associated with hyperkalemia, it is important to know that many patients are asymptomatic, even with high potassium levels. Muscle weakness is the classic symptom of hyperkalemia. It typically starts distally at the lower extremities and is ascending. It may even progress to trunk, and it can even lead to flaccid paralysis, resembling Guillain-Barré syndrome. Muscle weakness is caused by impaired neuromuscular transmission. The increase in extracellular potassium decreases the ratio of the resting electrical potential, making it less electronegative and partially depolarizing the cell membrane. That leads to weakness or even paralysis. Also, hyperkalemia can lead to metabolic acidosis due to an interference with renal ammonium excretion. However, the most prominent consequences of elevated potassium levels are cardiac arrhythmias and their pre-stages, which can be seen in the ECG. The usual sequence of ECG changes reported is peaked T waves, you can see it on the figure, prolonged PR interval, progressive widening of the QRS, sine wave patterns, ventricular fibrillation, and asystole. In a retrospective study by Durfee and co-workers on approximately 200 patients found that bradycardia, junctional rhythms, and QRS widening were independently associated with adverse outcome of patients. Therefore, a classification of hyperkalemia into mild, moderate, and severe based on the potassium level and the presence of ECG changes appears reasonable, as shown before. Also, we do know from studies that ECG changes are more likely with rapid onset hyperkalemia and the presence of concomitant hypocalcemia, acidemia, or hyponatremia. But also, there are pitfalls with the ECG. It should be mentioned that the quality of studies performed on hyperkalemia and ECG changes is limited, and that cases are published from patients with very high potassium levels who did not show any ECG changes. As many as 1 in 2 patients with hyperkalemia are expected to have normal ECGs. We do know that the probability of ECG changes increases with an increasing of potassium. But we also do know that the ECG is insensitive for the diagnosis of hyperkalemia. In a retrospective study of Ecker and co-workers published in the Archives of Internal Medicine in 1998, approximately 130 patients with hyperkalemia were studied. They found that the prevalence of ECG changes suggestive of hyperkalemia was independent of the severity of hyperkalemia, which is also very interesting. On the other hand, we are facing artificial intelligence today, and modern computer-based algorithms of ECG analysis are evaluated to predict hyperkalemia with promising results. See, for example, the paper by Dillon in the Journal of Electrocardiology 2015, which is really promising and highly interesting. When do we have to think of hyperkalemia? What can we recommend to physicians? Are there any red flags that should trigger our awareness of hyperkalemia? Well, certainly, as we heard before, advanced chronic kidney disease and the presence of acute kidney injury can be considered red flags in patients. Moreover, underlying diseases such as heart failure or diabetes mellitus should trigger our awareness. Most certainly, medications such as inhibitors of the renin-angiotensin-aldosterone system. I'm repeating myself, but it's common and it's very important. Potassium-sparing diuretics are major risk factors for the development of hyperkalemia. In case of a combination of these risk factors, hyperkalemia may even be more likely. I would now like to move on to the management of acute hyperkalemia. Talking about the management of acute hyperkalemia, it is important to know that there is a relevant lack of high-quality studies on its optimal therapy. Many therapeutic options that are considered standard of care in many institutions are solely eminence-based without a fundament built on scientific evidence. Also, we do know that therapeutic protocols for hyperkalemia do vary relevantly between institutions and even departments in hospital. The recommendations for managements that will follow are based on the limited available evidence, as well as a condensed expert opinions as expressed at the KDIGO Controversies Conference on Potassium in 2018. First, I would like to give you an overview on the management of hyperkalemia. We are seeing on this slide 3 pillars. The first is membrane stabilization. For sure, it is not a definite solution for the problem of hyperkalemia, but it primarily helps avoiding complications in patients in terms of cardiac arrhythmias. Calcium salts are used to stabilize membranes. The second pillar is potassium shift. A shift of potassium from the extra to the intracellular compartment. Again, no definite solution, but it helps gaining time and avoiding complications. In this pillar, we are using insulin, beta-adrenergic drugs, as well as sodium bicarbonate. The third pillar is potassium elimination. Finally, it is the only available definite solution for the problem. Potassium can be eliminated theoretically by use of dialysis, loop diuretics, or potassium binders. We will now move on to the therapeutic algorithm we made in 2018 at the KDIGO conference. It depicts our recommendations for management of acute hyperkalemia, and I will discuss it in detail on the following slides. For outpatients, it is recommended to refer them to the nearest emergency department in case of relevant hyperkalemia or any new ECG changes found supposed to be associated with hyperkalemia. All patients with hyperkalemia should be placed on a monitor and continuous monitoring should be established. Additionally, we do recommend to perform a 12-lead ECG, and screening for hyperkalemia-associated ECG changes should be made. In case of presence of ECG changes or in any patients with a potassium equaling or higher than 6.5 millimoles per liter and no available ECG, calcium salts should be given in order to avoid arrhythmias and consequent complications. Calcium prevents ventricular fibrillation or tachycardia by stabilizing the cardiac cell membrane. The mechanism calcium works is that it antagonizes effects of hyperkalemia through effects on the threshold potential and the speed of impulse propagation. Calcium is usually effective within 1 to 3 minutes after application. It can be given repeatedly within 5 to 10 minutes in case of persisting ECG changes or recurring arrhythmias. Caution should be observed in patients with known or potential digoxin toxicity. We do know that hypercalcemia potentially increases the toxic effects of digoxin. However, in a recent study by Levine and colleagues on approximately 160 cases of digoxin toxicity, of which 23 received calcium, no life-threatening dysrhythmias occurred within 1 hour. There was also no difference concerning mortality between the groups receiving calcium or no calcium with digoxin toxicity. Calcium is available either in form of calcium chloride, which is potentially phlebotoxic, or calcium gluconate. Calcium chloride, on the one hand, contains approximately 3 times the amount of calcium as calcium gluconate does. It is recommended to either administer 3 times 10 milliliters of calcium gluconate intravenously, or alternatively 10 milliliters of 10% calcium chloride. In case of persisting ECG changes, or in case of resolving and recurring ECG changes, a repeat dose can be administered, as mentioned previously. On this slide, you can see the recommendations of the European Resuscitation Council concerning hyperkalemia. Again, it can be seen that the drug can be applied quickly and in repeated doses as needed. Calcium should not be given simultaneously with sodium bicarbonate due to the potential for precipitation. One should keep in mind that calcium does not lower potassium, and its duration of action, which is very important, is limited to 30 to 60 minutes. Depicted, you see an excerpt of the current ERC guideline from 2015. It is also strongly recommended to repeat the potassium measurement in order to confirm the presence of hyperkalemia and address the potential bias of pseudohyperkalemia. Pseudohyperkalemia, as mentioned before, can be avoided by not using tourniquets or limit the time of its use, avoid fist clenching, and process the blood samples taken rapidly, and avoid mechanical stress to it. Coming to the medications used for shifting, insulin and salbutamol are considered first-line treatments for the management of acute hyperkalemia. Insulin should be given intravenously due to the more rapid onset of action. Salbutamol is considered equally effective as insulin and also considered first-line management. Its application via nebulizer is considered safe and well-working. We are recommending a dose of 5 units of insulin intravenously with glucose in terms of, under circumstances where blood glucose is not exceeding 400 milligrams per deciliter, together or separate or as a lone standing therapy, or in combination with salbutamol, 10 milligrams via nebulizer. Concerning the evidence we do have about insulin in the management of acute hyperkalemia, I would like to mention a systematic review from 2015 performed by Harrell and Kemmel. They were able to include a total of 11 studies. Interestingly, it was found that 10 units of insulin were equally potent in lowering serum potassium levels as 20 units were. Moreover, it should be noted that a total of 20%, 1 in 5 patients, experienced hypoglycemia with significantly higher rates with 20 units of insulin. So, extrapolating from the systematic review, we can see that 10 units of insulin are equally potent as 20 units, with quite lower rates of hypoglycemia. However, it should be noted that 9 out of the 11 studies were considered biased by the authors. I'd also like to mention a more recent study performed by McNicholas and colleagues. The authors conducted 2 audits on patients with chronic kidney disease or end-stage renal disease treated for hyperkalemia. The first audit took place in 2013, when 10 units of insulin was the standard dose for the management of hyperkalemia. The second audit was performed in 2015, when the standard dose was changed or reduced to 5 units. Interestingly, the authors found no difference with respect to delta potassium between the 2 groups. In absolute numbers, the rate of hypoglycemia was lower in the 5-unit groups, namely 28 versus 54%, so almost halved. However, the study was not designed to finally answer the question due to its design and the co-treatment with other agents. Still, we do get another hint that lower insulin doses are probably sufficient. Coming to salbutamol. In a Cochrane systematic review from 2015, Bedderink and colleagues focused on pharmacological interventions for hyperkalemia. They were able to include a total of 247 patients in a total of 7 studies. Due to the heterogeneity and lack of provided data, a meta-analysis was not possible, unfortunately. Concerning salbutamol, the authors found that administration via a nebulizer was effective in lowering serum potassium. 20 milligrams were more effective than 10 milligrams. However, there were also side effects reported: an increase in heart rate, tremors, palpitations, and anxiety may be unwanted, but prevalent. On basis of the present data, the authors consider both salbutamol as well as insulin as first-line interventions for acute hyperkalemia. Also of note, currently, there is a prospective randomized controlled trial in several institutions in France, still recruiting patients, investigating the effects of insulin and dextrose versus salbutamol versus a combination of both. It's called the INSACA trial. You can see clinical trials for more information on this interesting study. In all patients with relevant chronic kidney disease and hyperkalemia, dialysis should be evaluated. Additionally, dialysis is the ultimate option in patients with therapy-refractory hyperkalemia. Frequent potassium controls are indicated in all patients. A lowering of serum potassium below 5.5 millimoles per liter before discharge from the emergency department was recently shown to be associated with a decreased mortality. So probably it is reasonable to lower the potassium more strongly before discharge from the emergency department or intermediate care unit or intensive care unit before you discharge the patient to the normal ward. And last but not least, don't forget to clinically evaluate the patient and perform a thorough clinical examination, including volume status and a detailed history. Coming to dialysis. Dialysis is considered one of the definite therapies for hyperkalemia due to its potential to eliminate potassium. However, rebound hyperkalemia is possible, and the incidence of it is not really known. Additionally, we do not know about the role of transcellular shifting prior to dialysis. There is one retrospective analysis in emergency department patients with hyperkalemia, which found a total incidence for rebound hyperkalemia of 35%, so 1 in 3 patients after dialysis, and 15% of patients had rebound hyperkalemia and the need for recurrent dialysis for hyperkalemia. However, the authors found no association of prior potassium shifting with recurrent hyperkalemia or recurrent dialysis need in these patients. Taken together, we should keep in mind that even after dialysis for hyperkalemia, potassium should be monitored and that rebound hyperkalemia is a real and present danger for the patients. Coming to the further care for hyperkalemia. In addition to the measures mentioned before, it is strongly recommended to perform a critical review of the medications taken by all patients with hyperkalemia. Temporary discontinuation of inhibitors of the renin-angiotensin-aldosterone system is advisable, as it is with other medications provoking hyperkalemia. Think of the underlying condition and whether it can be treated in order to treat hyperkalemia or its recurrence. Dietary instructions may be helpful, especially in patients with chronic kidney disease. In order to see the therapeutic algorithm presented now, you can see the paper published on the conference report in Kidney International early in 2020, a recent publication on the management of acute hyperkalemia in emergency department patients, published in the Journal of Emergency Medicine. Well, I will now move on to therapeutical options, which are in some centers well established and used. However, available evidence for them is scarce. So we are moving on to the known unknowns of hyperkalemia. Concerning potassium shift, we heard that sodium bicarbonate is an option. Sodium bicarbonate is a well-known therapeutical option for the treatment of hyperkalemia, especially in patients with more severe kidney disease. It should be noted that there is almost no evidence for the use of sodium bicarbonate in the treatment of hyperkalemia. It can be considered in acidotic patients, but should be used with caution in patients with or at risk for volume overload. The Cochrane review on pharmaceutical interventions for hyperkalemia by bettering, mentioned before, concluded that the recommendation for the routine use of bicarbonate cannot be made in absence of acidosis. You can see it on the slide. IV sodium bicarbonate appears less effective than either salbutamol or insulin dextrose. In the absence of severe acidosis, we feel there is insufficient evidence to justify the routine use of bicarbonate in the acute management of hyperkalemia. But I would like to note the evidence is very small. Moving on to another field of uncertainty in terms of potassium elimination, loop diuretics. They are commonly used in non-anuric patients with hyperkalemia. Interestingly, there is no single study, no studies, investigating its use in hyperkalemia to the best of my knowledge. The drug may be beneficial in patients with hyperkalemia and volume overload, but caution should be used in dehydrated patients or patients with known allergic reactions to furosemide. Another issue in the management of hyperkalemia and potassium elimination are potassium binders. Potassium binders such as sodium polystyrene sulfonate, sodium zirconium cyclosilicate, or patiromer are also frequently used in the management of hyperkalemia, especially in chronic hyperkalemia. Again, there is a lack of evidence for the use in acute hyperkalemia, and there are concerns about gastrointestinal toxicity. Coming to patiromer. In a first pilot study, Rafik and co-workers randomized patients with end-stage renal disease to either standard treatment, which was defined as an intervention provided by the clinician according to the individual practice pattern or hospital protocol, or standard of care plus 25.2 grams of patiromer orally. There was no difference in adjusted mean serum potassium between the standard of care group and the patiromer groups at 6 hours. However, 2 hours post-treatment, the serum potassium of the patiromer group was lower than that of the standard of care. Mean potassium levels were significantly lower at 2, 4, and 6 hours compared with baseline in the patiromer group, but only at 4 hours in the standard of care group. The rate of change of potassium at each time point versus baseline was not different between the groups. Also, no difference was observed in doses of insulin or salbutamol used. Also, there is a trial registered at clinical trials, the so-called Platinum trial. It is aimed at including 300 patients with hyperkalemia in the emergency department again, but it's not yet recruiting patients. Moving on to sodium zirconium cyclosilicate. Peacock and co-workers performed a prospective randomized controlled trial on emergency department patients again, presenting with potassium equaling or above 5.8 millimoles per liter. All patients received background insulin as glucose at the discretion of the physician in charge. Patients were randomized to either placebo or 10 grams of CS. 25 grams of glucose was given unless glucose exceeded 400 milligrams per deciliter. Insulin was given to patients at a dose of 0.1 units per kilogram body weight. Additional treatments were given if necessary at the discretion of the physician. Primary study objective was to assess the effect of CS versus placebo, in addition to insulin and glucose, on the reduction of serum potassium levels at 4 hours after the start of dosing. Although the study planned to randomize 132 patients to enable adequate statistical power, only 126 were screened and only 70 were randomized, 33 to the CS group and 37 to the placebo group. A reduction in mean serum potassium levels was seen in both treatment groups after 4 hours, with a numerically greater but not statistically significant reduction in the CS group than the placebo group. To my mind, the absolute difference in the reduction in serum potassium was not only statistically insignificant, but also clinically. It was 0.36 versus 0.25 millimoles per liter. However, a numerically greater proportion of patients who received CS achieved a serum potassium below 6 millimoles per liter during the study period compared to the placebo group. Another important finding was that a numerically lower proportion of patients in the CS group required additional potassium lowering therapy due to hyperkalemia compared with placebo, despite similar reductions from baseline in serum potassium at 4 hours between treatment groups. So taken together, the new potassium binders on the market, evidence is low, but the first results in these pilot studies are promising to my mind, and they may be an option for the future. We'll now come to the end of the webinar, and I would like to come to my conclusions. We do know that hyperkalemia is common in the overall population of patients, and especially in the emergency department population. Risk factors for acute and chronic kidney diseases, as well as commonly prescribed medications such as inhibitors of the renin-angiotensin-aldosterone inhibitors. Consequences of hyperkalemia may be very serious for the patients, with potential for malign arrhythmias or even death. Management for acute hyperkalemia is based on 3 major pillars: membrane stabilization, a potassium shift from the extra to the intracellular compartment, and potassium removal. We do know that the evidence is small for the management and that studies are urgently needed, especially for the new potassium binders, sodium bicarbonate, and also diuretics in the use. We do have some new evidence, as we saw, concerning potassium binders, and I think we should be optimistic for the near future, but high quality studies, prospective randomized controlled trials are really urgently needed. I would like to thank you now, and we're open for questions. Brenda.
Thank you very much, Gregor, for that excellent overview of the diagnosis and management and some potential promising new strategies for treatment. We do have the moderated question period is now open, and we do have some questions here. So I will just begin with the questions as we have them. So the first question asks if we can use insulin combination with salbutamol. So I wonder, Gregor, if you could speak to the use of insulin alone versus salbutamol alone versus the combination of the two together.
Mm-hmm. In fact, we do have some evidence on this issue. The use of insulin and or glucose alone or in combination with salbutamol is possible, and it's considered safe. So you can use either of the medications alone or in combination. It's considered safe, depending on the degree of hyperkalemia.
And would you typically use, is there in some instances when you would prefer to use both together?
Personally, in my clinical practice, it depends on what is the degree of hyperkalemia. Do I have a patient with acute hyperkalemia and ECG changes? I usually use it both in combination. I give insulin, low dose, 5 units of insulin, and salbutamol via nebulizer. That is what I do. If you do have not a potassium that is not too high, like, I don't know, 5.9 or so, and you do not see any ECG changes which can be attributed to hyperkalemia, you can easily go for the use of one medication.
Thank you. I was really pleased to hear that there's actually a trial underway looking at head-to-head comparisons as well as a comparison of the combination that will really provide useful evidence. The next question speaks to the use of dialysis in hyperkalemia and the indications for initiation of dialysis in a patient with hyperkalemia.
In fact, it's a difficult question. I think when you're confronted with a patient with acute hyperkalemia and severe underlying chronic kidney disease, think of dialysis early. Think of dialysis early in patients who are already having end-stage renal disease or are on dialysis. Also think of dialysis in patients who already received insulin, glucose, who already received salbutamol, who are refractory to your therapy for lowering of the serum potassium. Then you have to get in contact with the nephrologist early in order to, well, get dialysis for the patient.
Great. So yeah, really dependent upon their underlying renal status.
Exactly. Exactly.
Yeah. So lower threshold for initiating dialysis in somebody who's dialysis dependent
Yes.
versus those who failed the medical therapy. Great, thank you. The next comment is the effect of salbutamol is not as predictive as insulin, and with as many as 30% showing a decrease of less than 0.5 millimoles per liter. Also, the dose is 4 times required that use for bronchospasm and may be arrhythmogenic. So I wonder if you could just speak to kind of the risks associated with the use of salbutamol for acute management.
So for sure, with the use of salbutamol, there is a relevant risk of unwanted side effects. If you ever tried salbutamol yourself, you may know what I'm talking about. The dose is high, but the risk is acceptable to my mind. Also, the studies consider it safe. And also, as we recommended at the beginning of the therapeutic algorithm, you should use monitoring for all patients and use of 10 milligrams. That's why we recommend the lower dose is, to my mind, a valid option. 20 milligrams are also considered safe in the systematic review from Cochrane review, from Bettering. But as said, if you start with 10 milligrams, I think it's more reasonable in order to avoid these complications and still see whether it works.
Thank you. The next question is a related question, and it says, should we avoid giving salbutamol when a patient has a history of MI and takes beta blockers?
Certainly, that is a good question. Personally, I would, in such a patient who would be at risk with the use of salbutamol, I would go for the insulin first, and only if potassium cannot be lowered by this approach, salbutamol might be an option. So I would be careful in these patients, yes.
Okay, thank you. The next question refers to dialysis in hyperkalemia, and it says, how long after dialysis should you wait before you recheck the potassium, and what dialysis potassium should be used in the bath?
This is a very good question. The thing is, we do have only very little data on the way potassium is working after dialysis. So we do see that 1 in 3 patients has rebound hyperkalemia. We don't see the association with prior shifting in this one, at least in this one study. You should be aware of, that is true, and I think you should recheck potassium at least 2 hours after dialysis.
And the potassium bath, in the dialysate, I could respond to that one. I think the consideration of potassium bath is on, you have to take into account the degree of potassium prior to dialysis and the potential arrhythmogenic effects of too rapid a reduction. So I think those are important considerations when you're deciding what potassium bath to use in the dialysate. The next question actually is about calcium gluconate, and it says, what is the consensus on the use of calcium gluconate for membrane stabilization? And is calcium chloride superior to calcium gluconate?
So it explicitly is recommended in patients with shock. You can give it as a bolus that is recommended by the ERC. We don't know what is superior. What we do know is that the amount of calcium contained in calcium gluconate is approximately only a third as in calcium chloride. So calcium chloride has the higher concentration. Using calcium gluconate, you should use a higher dose. You should use 3 times 10 milliliters, but it should be equally effective. But we don't have real data on that.
The next question says, how can we have your slides? And the webinar will actually be posted on the ISN website and will be available there. Thank you for that question. The next question is about hypoglycemia, and it says, hypoglycemia is common with insulin and dextrose. Is there a standardized protocol recommended to check and manage blood glucose, the frequency and duration specifically?
In fact, the danger of hypoglycemia is very present. As we saw, 1 in 3 patients experience hypoglycemia. No, there is no standardized protocol. I would recommend to check blood glucose 30 minutes after application of insulin for the first time, and then do it regularly.
The next one is with respect to assessment of hyperkalemia, and it says, what is best to assess hyperkalemia, serum sample or venous blood gas?
We do know that the serum sample is more exact. That is what we do know. We also know that depending on the make of blood gas analyzer you have, it can be reassuringly exact. What is helping with the blood gas sampler is you have the result very quickly available. And I guess if you're not having only one value, but you can see a trend also with the blood gas analyzer, it is a reasonable option to check it with this one.
The next one refers to toxicity of insulin and glucose and says that the toxicity of insulin and dextrose is significant. A large number of patients get hypoglycemia, which can cause major harm. And so they're wondering, for patients with potassiums of 6 to 6.5, does using SCZ early might be safer than insulin and dextrose, i.e. used before insulin and dextrose?
Well, that is a very good question. We don't know. Actually, we don't know. Insulin and glucose is potentially harmful due to the risk of hypoglycemia, which can be avoided if you check the blood glucose regularly. But in terms of the effect of CS, for example, or other potassium binders, we have almost no data. I showed the 2 available studies before.
The next question asks about calcium gluconate or chloride. Can you give calcium gluconate or chloride as prophylaxis for arrhythmia in hyperkalemia more than 6 without ECG changes?
Good question. Depending on the paper you're reading and there is not quite a lot of evidence, as we do know. There is a UK Renal Association guideline on the management of acute hyperkalemia. Depending on where you read and what the opinion of the author is, it is recommended that you give calcium at 6 millimoles or 6.5. We decided to give it starting at 6.5 without ECG changes. You certainly can give it earlier. Be careful, as mentioned, if the patient is on digoxin or digoxin toxicity might be possible in this patient, but otherwise, for sure, you can give it here. Remember that the time is 30 to 60 minutes for its action.
Thank you. In your talk, you spoke specifically that this was the management of acute hyperkalemia, distinct from chronic hyperkalemia. And so a question is, what is the difference between acute and chronic hyperkalemia?
Mm-hmm. It is pretty similar to disorders of serum sodium. Maybe not to the same extent, but the mechanisms are similar. If you're confronted with a patient with chronic hyperkalemia, you might have a certain tolerance. We do know that the arrhythmic potential of hyperkalemia is greater in patients who develop the hyperkalemia quickly than in those who develop it chronically. So in patients with acute hyperkalemia, it is for sure advisable to lower the potassium more rapid and to act more quick than in patients with chronic hyperkalemia. I think this is the major difference.
The next question says, my patient has acute kidney injury with a potassium of 8.0, and the patient has been indicated for dialysis, and they wonder how they can use a potassium bath, 2 millimoles or higher.
Brenda, would you like to answer this question?
So again, it refers to the degree of reduction in potassium and the potential arrhythmogenic effects of that. So I typically wouldn't use anything lower than a 2K bath in these patients with hyperkalemia. You may need to dialyze them again, the next day, depending on the degree of elevation and what their repeat potassium is after. But I typically would use a 2K bath as the lowest bath in that instance.
Thank you.
The next question is about the use of sodium bicarbonate in hyperkalemia. In the case of hyperkalemia associated with acidosis, when should we use sodium bicarbonate? Is there a degree of acidosis or level of pH?
We don't know. We are quite sure that sodium bicarbonate has absolutely no value in patients with hyperkalemia without metabolic acidosis. You can use it in patients with probably any degree of metabolic acidosis, but what is really an issue is think of volume overload. Patients shouldn't be volume overloaded, otherwise it is contraindicated. But as we said, it's for sure not standard of care.
The next question refers to the management and use of medical management versus dialysis, and the question is there a cutoff potassium for which you would consider medical management only, or for which you would think dialysis is urgently warranted?
Talking of patients without underlying severe chronic kidney disease, I would say no. You can see patients with really high potassium levels, with only medical management. In whom you won't see any problems, and where you can lower potassium without any problems. And there are other patients with the potassium levels not so high, who finally will need dialysis. Yes. So no, I cannot see any cutoff.
The next question is about treatment of a patient with hyperkalemia and acidosis. So it says, should we treat hyperkalemia or acidosis first?
Well, good question. If you give sodium bicarbonate, the mechanism will help you with both. It will help you with acidosis, and it will maybe helps you with hyperkalemia.
The next question, if I understand correctly, is with respect to the duration of onset. How much time is required by different interventions to work? So what is the onset of insulin, for example, versus salbutamol versus both in combination?
Well, salbutamol is known to work approximately after 30 minutes, with its peak action 60 to 120 minutes after the application. Insulin is similar concerning the new potassium binders. The data we have from these pilot studies, we see that probably in these pilot studies the observation period was too short, because the longer you see the patients, the more favorizable are the groups using the potassium binders, so their action of use is longer. But 30 minutes after the application, you should see an action with the conventional therapies. Calcium works after 1 to 3 minutes after application.
Okay. We've got a few minutes left for a few more questions. So the next one's with respect to patients who are already hypercalcemic. So if a patient is already hypercalcemic, do you still give IV calcium?
No.
Okay. Some of the questions have already been answered, so I'm just going to look through. We have a few minutes left. In the presence of a beta blocker in hyperkalemia, should we omit the beta blocker?
Sorry, I don't see the question.
So in the presence of a beta blocker, so if a patient's on a beta blocker and has hyperkalemia?
I see. If this is the only medication you can make out for a potential cause of hyperkalemia, and the patient is not absolutely needing it, yes, you can think of it. But usually it is not, a beta blocker alone is not causing severe hyperkalemia.
This is a related question in terms of management and medications that may be risk factors. So if acute hyperkalemic patients have a low GFR less than 30 and type 2 diabetes and we're on an ACE or an ARB, should we stop the medication forever, or should we reintroduce the medication in the future?
After the first episode of acute hyperkalemia, I guess it is important to restart the medication after the acute episode of hyperkalemia is managed. But it is important to assure that other confounding factors, that other factors contributing to the hyperkalemia are addressed, for example, dietary instructions or other medications that would trigger hyperkalemia. But the medication, the RAS inhibitor, is important for these patients, and I guess it is reasonable after the first episode of hyperkalemia to restart the medication.
One question about potassium binders, and it says, what is your take on the use of K-oxalate in resistant hyperkalemia? What is in terms of potassium binders?
Yes.
What is your take, or what is your recommendation on the use of K-oxalate as a potassium binder in resistant hyperkalemia?
Well, I think there is a potential for these new medications, and honestly, with therapy-resistant hyperkalemia, I would give it a try. And yeah.
Okay. In time for one last question, and we'll just take the last questions. There have been some similar ones, so I've scrolled through some of them. There's been some great questions. So the last one again says, do we need to check the blood level of calcium before giving calcium gluconate or chloride in hyperkalemia with ECG changes already?
If you have the option to do it, for example, by blood gas analysis, I would do it.
Okay.
But if I don't have the option, I would not avoid giving calcium in case of ECG changes.
Thank you. I'd like to thank you, Dr. Lindner, again for an excellent presentation. It was very clear and really it showed the evidence that's available and the areas that we need continued evidence in the acute management of hyperkalemia. I'd like to thank the ISN for the opportunity as well, and I'd like to thank all the attendees and the great questions that were provided. Thank you, everyone, and I wish you all a great day.
Thank you. Goodbye.
Bye-bye.